So clinical practice guidelines are showing and suggesting that it's not an absolute to have or to require a repeated cesarean section after having had a prior cesarean section, that vaginal birth attempts are worthwhile or noteworthy or possible. However, it is strongly recommended through literature, through the 3 studies that I have compiled and shared with you thus far, both through Curtin et al., Mew et al., as well as Bifford and Jansen, is that the attempted births after cesarean section should not be completed at a home attempted birth site. So this needs to be with the possibility and capabilities of having rapid treatment options and aggressive treatment options for the mother or child if necessary. So again, we must consider and respect the patient or mother choices on the attempted type of delivery that they're seeking. So something that we haven't talked about thus far, though, because this is going to be an individual who is at a medical facility, what about the decision-making based from a physician's standpoint, and how do they affect the process of somebody who has had a prior cesarean section and is seeking a repeat birth of whatever type? So a study conducted by Rietveld et al., and this was actually a Dutch study conducted in the Netherlands, looked at different factors associated from the physician standpoint on how it affects birth rates. And it actually found that physicians constantly had a comparative assessment, they termed it, taking in and addressing multitude of factors as they make the decision on whether or not this cesarean threshold would be reached. So certain circumstances are going to swing the pendulum towards having a C-section. Other assessment standpoints are going to swing it towards the possibility for a successful vaginal birth. And the 3 influential factors that were found through this study were based off of the physician, and found that physicians that have more experience and or just personality-wise have less anxiety correlate with an increased chance of successful VBAC deliveries. Similarly with the patients, as physicians are constantly seeing how the mother is doing during the labor process or even just during the antepartum process and seeing the thoughts or feelings or discussions with the possibility for delivery options, found that patient preferences have a huge bearing on the type of delivery that will occur. But, however, there is a state of mind and well-being considered during the labor. If the mother seems like she's doing really well, okay, that chance for successful vaginal delivery will be increased. If the mother is seemingly not doing so well, they're going to swing closer to that cesarean threshold. And then thirdly, the delivery. Again, we're talking about our prior delivery, our prior C-sections. It needs to have this sort of all stars aligning. There needs to be good fetal presentation, an appropriate gestational age, and low risk factors. So low risk factors associated to what we had spoken about earlier, that there is no placenta previa, placental abruption, placental accreta, which is the placenta growing into the uterine wall. None of those complications are occurring. If that's the case, then we're very much so going to be sort of swinging towards that cesarean threshold. The purpose of that is just because physicians are really trying to prevent attempts at that emergent or unplanned cesarean section. Again, think a few slides back to that graph where we were showing the maternal risk of complications associated with failed trials of labor, which resulted in unplanned cesarean sections, and how much higher those maternal risks were. Similarly, those same risks are going to be transferred over to the fetus if this is not a controlled environment where it's an elective cesarean or sort of a ho-hum, boring, with no complications vaginal delivery after cesarean section. So the only sort of absolute mark that this study identified is that if there is fetal bradycardia for whatever reason, and the physician quickly and astutely works towards making certain that it's not a result of maternal hypotension or increased uterine hyperstimulation, that is sort of that threshold where no holds barred, we need to do a cesarean section in order to guarantee that we're going to have a, first off, a live fetus, neonate born, as well as the risk or the possibility of complications associated with those life-threatening ones from the prior slide. Now this second comparative assessment sort of aspect here would be this variable cesarean threshold. And this is sort of what is shown here from the standpoint of this organizational norms or standards, which sort of have a outside bearing on it. And during this study, it was actually seen that the place of work sort of dictates the degree of how quickly a cesarean section is completed, where one physician actually identified that there was a decreased incidence of cesarean sections after moving from a non-academic, non-teaching hospital. And then there's also this sort of component where the ability to assemble the necessary surgical team for the cesarean section if needed, if that can be assembled in a very quick manner, then the cesarean threshold might not be reached quite as quickly. Conversely, if it takes a lot more time to get the surgical team prepped and ready, then that cesarean threshold, because of the safety of both mother and fetus, might be reached a little bit more quicker as compared to facilities that have that on a 24/7 quickly ready component. And then also, it's also this like personal or collegiate medico-legal actions or consequences that this study refers to, where it's either the physician or maybe the physician group associated with a specific physician, where if there are legal consequences already associated with that, they might be a little bit more quicker to perform a cesarean, again, just because the whole goal is to ensure that they have sort of that controlled environment, so to speak, as you hear about in surgical worlds, that they can extract the fetus where it can be that they can perform interventions on the fetus, not secondarily through the mom, in order to improve the fetus if necessary. And then this last mark is just the societal changes, where, again, because of these clinical practice guidelines that we identified earlier, C-sections are more the norm as compared to these, past, if you consider studies completed like 20, 30 years ago, where all that was available were vaginal births. Now we have the ability to do cesarean sections, so that's more that securement of that healthy fetus. But then also taking that into effect and consideration of that desire for certain people to have the vaginal birth because of those clinical practice guidelines now saying that that's okay after a prior C-section. So what Reitveld et al. Identified is that it cannot just be written protocols or guidelines. That's not enough in just simply trying to come up with decisions towards whether to have a type of delivery or not. It needs to be individualized treatment options based on a whole host of variety of factors like we just covered right now, as they take into consideration whether a vaginal birth will happen or whether a C-section birth will happen. So then that obviously just flows into our evidence-based practice guidelines. And specifically, there were two articles, one by Shorten et al. And Chincombe, that found that the implementation of decision aids and counseling necessarily 100% affect the rate of either cesarean sections or vaginal births after cesarean, but made a more individualized, patient-directed decision model rather than you had a prior cesarean section, therefore you should have a repeat cesarean section. It takes all those aspects that we've talked about in these prior slides, the maternal risks, the fetal risks, and presents all that information to the patient. And both of these studies actually did studies showing that they presented information to the patient at 28 weeks of their term pregnancy, and then again at 32 to 35 weeks. And then sort of based on those two different decision aids and information that they counseled individuals upon, allowed them to make that decision so that they were the best and well-informed on that type of decision. Again, so this would just simply be from the patient standpoint. Now, my second point here with the clinical adeptness and skill is, as the Rietveld experiment had shown, that this is not just simply the maternal or the patient perspective, but also incorporating the physician. The physician or practitioner for the birth needs to be aware of their own personality characteristics and mechanisms, which can sort of affect the underlying assumptions or concepts and adjust them to fit the present situation, which is considering the best patient outcome for the scenario in front of the person. So in order to bring this about, there are going to be some pretty significant hurdles. For OBGYN providers who have already completed their schooling, it's going to be a huge undertaking to sort of re-educate and have this buy-in factor of convincing them that this should be the new standard of practice in order to meet patient desires, but also to ensure that the best outcomes are occurring because of those patient perspectives and requests. And also the education showing that it's not a absolute, the fact that you have had a prior C-section and you need to have another repeat or elective C-section. And then that sort of goes into that public understanding, where personally there's been countless friends, family members, or acquaintances that I'm aware of that have had a prior C-section, and then because of a lack of education, they just automatically think that they are going to have another repeat cesarean section, and it's not educated upon them by their providers that vaginal birth is a possibility. So, in conclusion, again, the whole decision process for coming into a delivery option after a prior cesarean section is extremely complex. It deals with a multitude of various factors which make that decision process extremely difficult. There is no right or wrong answer, but hopefully through these slides you have seen that complications are increased if there is a prior cesarean section, but also that there are options available in order to have a vaginal birth after cesarean section. Not risk-free. Certainly there are inherent risks associated with either type of birth, and they're optional. They're available to occur if you've had a prior C-section, but it's more or less an educational standpoint that needs to be taken so that people can understand those inherent risks. Based on those inherent risks, we need to have this individualized treatment. So those people who have had prior C-sections are presented with the information about the increased instances of complications after cesarean section and attempted vaginal births, as well as presented with the option of not going through labor but having a repeated elected cesarean section. So in reflection, this literature review and synthesis process has just been exhausting. I enjoyed it after I started getting into it and tying all this information together, sort of, but in all, I'm glad it's over. But I feel like I have learned a lot. It's taken lots of time, lots of hard work, just in comparing and contrasting the different studies and articles, and even difficult to sort of nail down some of the associations for best practices due to the large variety of factors associated with this topic. So I'll just simply leave you with the references that I've used, and thank you very much for listening.